So, good morning, everyone. Let's start the day 3 and let's get these nerves right. I don't know about all of you, but this used to be the most difficult day for me, for sure. So, this is all about strabismus and neurophthal. And to add on, we have the FRCS and ICO module, and we hear from the young ophthalmologists what they have to say to you and how they would like to inspire you. So, we start with the strabismus 1 session. I request the chairs, Dr. Jaspreet Sukhija sir and Dr. Sumit Monga sir, to please take the dais. So we start with the first talk, and that would be a little shuffle here. So we're starting with Dr. Sumit Monga sir, who is our own faculty at Center for Sight Delhi. And the topic that he will be taking up is practical aspects of refraction and prescription of glasses in children. So over to you, sir.
Morning, everyone. It's always a pleasure, to be at iFocus, and I'm sure you're having a good time. So, it's indeed a pleasure to commence the pediatric ophthalmology session. And in fact, this is one topic which is very dear to me, and I just wish, some of the things, you could imbibe, because as you move along in your career, it's really the sense of refraction, and especially when you're dealing with kids, that's something helps them lifelong. So what you do from them today would be consequential for the life ahead. So let's get started. And in fact, this was not supposed to be an interactive session, but with all the intelligent young minds, and that too in a pleasant morning, I think I should learn from you rather than the other way, or in fact a little bit mutual. So let me just give you a situation, because the practical situations are the best modality to really learn about points. So may I just present before you a 3-year-old child who had this kind of refraction plus 1.5 diopter sphere. He had aligned eyes, he had normal anterior and posterior segments, and the child is not really cooperating for vision as such. Now, what exactly would you like to? Yeah, so somebody said nothing. So that nothing is also an option, So we have nota and, so nothing is also an option, but that option has to come with a solid background. So what basically he meant was that in children, you have this process of emmetropization where the optical components, they are getting to normalize. That means, yeah, they're moving towards, emmetropic status. So this is pretty normal for a child. And what exactly you call normal? So we have some nomograms where at different ages, for different type of refractive errors, you have these cutoffs, originally given by American Academy of Ophthalmology, and now our own All India Ophthalmic Society also has, for past 2-3 years, prescribed these nomograms with a slight variation. You can actually just get it in the IGO 2019 issue, so just search for it. So the bottom line is that the refractive errors in children require prescription only if they're amblyopigenic enough. That is one thing you always remember. Let's move on to a situation, where a 4-year-old just came with 680 in vision in one eye, 612 in the other eye. The child had aligned eyes and movements were okay. Cyclopegic refraction, moderate kind of hyperopia, plus 4.5. And the child was cooperative, plus 2.5. He was accepting and, he was improving, not fully. So the physician in charge, called for a post-mediatic test and, just gave it. Do you have a different approach? Anything else? Did we miss anything? Sorry, do we have a moving mic here? Okay. So, okay. Yeah, they can just shout out, I mean, you can just shout out like that. Yeah, so That is very important actually. Somebody just shouted PBCT because this is the child actually, unless you see the orthoptic status of this child, that means the child actually had a moderate hyperopia. And what if, the child had this kind of mild ESO deviation, and if you really test the stereoacuity, the stereoacuity wouldn't be there because the child is actually managing more with one eye. And in this situation, we should have actually been going for the full correction rather than the under correction. So that is a point to understand, that you have to understand that the hyperopia or the hyperopic astigmatism is an amblyopigenic stimulus, and unless you actually see the orthoptic status, you don't really know exactly whether to fully or undercorrect. And if the child was indeed orthophoric and with good stereoacuity, which you can actually just test grossly, and more will be coming up in coming sessions. So then you can actually just give according to the best possible acceptance with a little fogging. And sometimes when you have hyperopia more than +6 diopters, you may actually be inclined to give full correction in these cases, because they are already quite an amblyopigenic number, irrespective of the orthoptic status. So before checking the hyperopic refractive error, apart from the child's visual response, which may or may not be available all the time, you please check the eye alignment, fixation preference, binocular vision status, and overall need of the child. What did the patient come for? An older child may actually just come for asthenopia because of the latent hyperopia, while a younger child may have no complaints at all, but still may have esodiviation leading to amblyopia. So that is very, very important. Okay, so we have another child walking with this kind of vision. He just said that I'm not able to see since about a week. 636, 618 vision in the either eye, and he has these kind of refractive errors, and other things are pretty okay. And you do cycloptic refraction, there's really nothing there. So basically, we have a recent vision loss, we have gross disparity between dry and wet refractions, and the cycloplegic refraction is almost plano. Does it ring something? Yeah, so this is very intelligent audience. So basically, when you have ciliary muscles which are contracting, the zonules relax, and the curvature of the lens increases, and the myopic shift occurs. That means if the accommodation goes, vary, you may actually have spasm leading to the myopic shift. You will have a myopic shift. But this is basically a pseudo myopia. It's not a real axial myopia. And this is really, the trend is increasing not only in children but in many computer IT users. So beware of this entirety, and all you basically need is a good cycloplegia and transient bifocals, because the near vision would go off. So this wouldn't really require that kind of myopic number. Sometimes we see these situations, people put on low dose atropines, with that kind of dry acceptance. So cycloplegic refraction is a must. So then we had a 6-year-old who had this unaided vision. Cycloplegic refraction showed a gross astigmatic number, a hyperopic astigmatism, and the optometrist just wanted, to do the PMT, and the child was cooperative enough, but he was not improving beyond 618. So what exactly should we do? I'll give you 4 choices. So just go through the choices. Either you will just do a PMT, give the refraction, you will go for alternating eye patching, and you might want to give the full correction of the cylinder, or you might want to give the slightly reduced cylinders. So in the interest of time, most of the people actually go for a little undercorrected cylindrical numbers. But the point to understand here is that if we reduce the cylinder in these cases, the child has already developed, amblyopia. That undercorrected cylindrical numbers would not, help you in that amblyopia management. And generally, it's a myth that children do not, tolerate the high cylinders. They tolerate it wonderfully well. In fact, more than 2 diopters of astigmatism is very amblyopigenic. And if we, have to prescribe the cylinders, that's because, we have different meridians, 2 different meridians in which the things are working. And accommodation is not really relieving both the meridians compared to just a hyperopic refractive error. That's why in these situations, we need to give or take out the amlapogenic stimulus, which is astigmatism. And beware that you actually are aware of, the spectacle fitting and centration, which is very, very relevant in a case of astigmatism. And of course, pentacam imaging, need to be done, at an appropriate time to rule out the corneal ectasia in these cases. So then we had a young child, didn't speak anything, had pseudo-strabismus. He came for strabismus, but we did the cycloplegic refraction and found that he had basically an isometropia, of 4.5 and 1.5. What exactly would you want to do? You would just want to wait and see, things later. He doesn't speak anything, but is there any other plan? So the point is that even anisometropia more than 1.5 diopters is amlapogenic enough. If we just leave the child now, tomorrow when the child would be wiser enough to give the responses, he would be amlapogenic anyway. So you have to, as a doctor, take the decision that, this is something which is to be prescribed. It's another matter that the child may not really use it all the time right now. That is something, which is not in our control, but the decision has to be very, very correct. And this is what you have to impress on the parents. So another example, a child who had retinal dystrophy and had this +4 diopters, hyperopic refractive error. Now the approach here is a little different. When you have a normal optical system working, you might say that, okay, we have these cutoffs. But when you already have a decompensated, system, where you would want to actually give as much as refractive error as possible. So depending on, the orthoptic status and other things, you need to take that decision. So the overall need of the child needs to be kept. So there are no, black and white rules here. And you should always have a working knowledge about the spectacle frames and the lens materials. So don't think that, it's not our job. It is our job because ultimately the patient is yours. So just avoid very large aperture frames, avoid rimless glasses, especially in the cylindrical numbers, because you need to have a good support. If there is an axis variation, the child may actually not complain, but still, that'll cause a problem. And of course, you should be aware of what exactly, like in children, because of the playful activities, you should avoid the glass lenses, sometimes very high numbers. People, for the sake of less money, because of the economy's sake, they go for glass. But actually, all children need CR39, that is the fiber lenses. And if you have a concern about the protective nature also that you need to give, polycarbonate material is something, you should go for. So the factors to be considered before prescribing spectacles in children: visual response, which ultimately is a subjective response. A child walking into your clinic for the first time may not give you the best of responses. So beware of that. And that is why the objective examination kicks in, where you have to see what age I'm dealing with, what is the magnitude of the refractive error, what is the ocular alignment, what is the binocular potential, is there an accommodation, which is happening, is there a lead or lag on the dynamic retinoscopy, or is the child already achieved emmetropization? So all this in the background, you need to just keep thinking about. Once you do it on a daily basis, everything comes automatically. And remember, it's not mentioned here, but ultimately what counts is the passion. If you want to give the child walking into a clinic who is innocent enough, that extra bit of time, that extra bit of effort, it all is worth it. Thank you very much.
Thank you, Dr. Sumit. That was a very good overview about prescribing glasses in children. And it's very important to know because especially in children who are unable to read, they are the toddlers or the preschoolers, how you're going to prescribe glasses? Would you prescribe them glasses? It's so rampant sometimes that they have been given some kind of a refractive error, and now they are confused whether they should be using those glasses or not. So usually hyperopia, a child is born with some amount of hyperopia, and this usually decreases. So it's about 2.5, and that usually decreases over the period of 1 year. So remember that. That's very important, The other thing is, if the eyes are aligned, as was readily said in the presentation, probably yes, you won't prescribe 4 to 5 diopters of hyperopia in an infant, but yes, if its child is myopic, then probably the myopia is going to increase over a period of time, and a serial follow-up would be what is required. Whether to undercorrect hyperopia, yes, but remember, if you have to undercorrect the same amount in both the eyes. Don't do 2 diopters in one and 1 diopter in the other, because that will lead to a difference in the accommodative amplitude. So undercorrect the same amount if you want to in both the eyes. With myopia, things are different. Whether the child is orthotropic or a myopic or has exotropia, it will all depend on that. But if the eyes are aligned, probably yes, the myopic correction should be given depending upon the amount of the refractive error. So that's all I have to say for this presentation. Any questions? Yeah.
Yeah, please come to the mic, the aisle mic. Just speak into that. Speak into the mic. Yeah.
Sir, as for your fifth case, there is an isometropia of right eye is 4.5 and the left eye is 1.5. So in this case, we correct full correction देंगे या फिर उसमें भी हम?
No. Actually, again, the point is that in the eye, like 1.5 is on the left.
Yes. Sir.
So in that, you might actually just give a plano.
Yes.
But in the other one, you might just undercorrect, say by 1.5 diopters. So 3. So that also comes with practice, that sometimes how much to undercorrect. Because if the child is otherwise orthotropic, he came for strabismus. There is no strabismus at the moment. But we don't know that hyperopic of 4.5, transiently, it may leading to some kind of deviation. So we can always revise the numbers later on. But the initial correction that I would want to give is, plano and +3, if that is the net refraction. Thank you so much. I think we'll carry on, with these topics later on in the day. And it is with utmost pleasure that I invite Dr. Vinita, my teacher and mentor, in the training period. She's an additional professor in ophthalmology at AIIMS Rishikesh, and she has surgical expertise in all subspecialties, but she's a pediatric ophthalmology and strabismus person at heart. Looking forward to learn from you, ma'am. Dr. Vinita Gupta.
Yeah. Good morning, everyone. ऐसा व्यू क्यों आ रहा है? पूरा कंप्लीट व्यू क्यों नहीं आ रहा? So I'll be talking in brief about this enormous topic. It's a huge task given to me. So I try to cover up only the basics which are required out of it. So while we're evaluating a strabismic patient, what is important? Our goal is to detect any visual problem which a patient has, as if there is any amblyopia which a child is having. We have to assess what is the binocular status of that patient. Then obviously we have to measure the deviation and characterize the type of deviation and know the cause for it as well, whether there is any neurological cause for it or is it just a strabismic restrictive pathology. So broadly, when we are seeing a patient with squint, we're classifying the squints as competent or incompetent squints. So I think everybody would be aware what is a competent squint. So competent squint would be where the measurement of squint is in all directions of gaze is the same, and for incompetent is not it's not true. So obviously that deviation is different in different directions of gaze. And obviously we have to need to find out whether it's a competent or incompetent. Incompetent causes usually are a restrictive or a paralytic pathology. So obviously we have to find out the cause as well. Now, these patients may present to us in many ways. They may present to us with asthenopic symptoms, which may be headache, eye strain, or they may present with refractive errors, defective visions because of the amblyopia being there. Or those with a recent onset of squints may present with double vision, or an abnormal head posture, or sometimes even past pointing and vertigo, especially in cases of acute onset of paralysis. While some patients, like parents, may come to you with children coming with a manifest deviation itself, or a deviation which may not be manifest all the times, but may be coming up intermittently, or there may be defective ocular movements, or some abnormal eye movements, noted nystagmus, which another speaker would be talking about. So whatever is the case, you have to take a detailed birth history, a detailed developmental history of the child, family history of any strabismus or refractive errors, treatment histories which have been taken in the past, And the age at the time when the onset was there is very important because it has a prognostic implication. Also the characteristics, whether it is intermittent or it is constant, again has a prognostic implication and also has a great role in your management. And then obviously, as I mentioned, the history taking, you have to know about the double vision, what were the precipitating factors for it, is there any trauma which precipitated, is there any illness which precipitated, any systemic disease, any neurological association, any other ocular associations which are there. For the examination now, this is a broad overview, but I'll not be able to touch on all the topics, so I'll be just discussing about the head posture, which you should know how to interpret the head posture. The visual acuity, obviously, you can go and read up the age-appropriate test because it's a huge topic on its own. So I'll be talking about the head posture, the cover tests, how to measure these deviations, and what is the oculomotor testing, and how do some adaptations, sensory and the motor adaptations to it. So let's start with the essential tools which are required. So as a pediatric ophthalmologist or as a squint person or as an orthoptist, whoever is working with you, you have to have these minimum things. A pen torch is always must, along with an occluder. Preferably a Spielman occluder also, because it will help you in picking up the dissociated deviations. The loose prisms work better if you're dealing with children because they may not cooperate with the prism bars, so loose prisms work better, but you should always have loose prisms and the prism bars both. And obviously the test for fusion, the various modalities for testing your fusion and your pseudopsis. And if you have synapto 4, that is an add-on, along with the camera, fundus camera, which helps in documentation of your findings. So the general inspection starts, visual acuity I'm going to skip because obviously, as I said, you have to use the age-appropriate tests for different ages. For the external examination, we start with, obviously, the first thing is the abnormal posture. So we'll have to look at the head posture, any facial asymmetries, any associated ptosis, any proptosis which is there, and examine the patient as a whole in the beginning itself, any gait, any dysmorphic features which may be pointing to any neurological associations. So compensatory head posture is the characteristic feature which is seen in the cases of incompetent squints, mostly paratic squints. And why does it happen? Because the head tries to come to the position where the eyes are maximally aligned. And this is to avoid diplopia, which is happening, to overcome the symptom of diplopia, or the double vision which the patient is having. And the direction of the head position would be dependent upon which muscle is paralyzed. It could be a combination also. So just remember broadly, if you say the face turn would be there in the cases when there are mostly horizontal deviations. Chin elevation depression will come mostly for the vertical deviations, but head tilt would come in whenever there's a torsional element which comes into play. To describe this, first I'll be discussing this in details, but for that it is to understand whenever squint happens, your binocular vision breaks down. So what it creates two things, confusion and diplopia. Now for ESO deviations, what is happening, confusion is usually taken off, like what is happening in confusion. Both the fovea are looking at different objects. So obviously there's a confusion created resulting in a retinal rivalry and then a cortical rivalry coming in, suppressing that. But for diplopia, why does it happen? Now what is happening, fovea of the normal eye is seeing at the fixation point, at the fixating target, but it is an extra foveal element, either the nasal or the temporal, depending on whether it is ESO or exo. Some other element has started coming and projecting, seeing that image. But the actual visual direction of that point, which has now taken up the function of fovea, or where the image is projecting, is going somewhere else. For ESO deviations, it is in the temporal field. So obviously, the patient would have an uncrossed diplopia. While for exo deviations, it is going into the nasal field. So obviously, the patient would have a cross diplopia because the point is now in the temporal tree of fovea. So what happens normally, an eye would, when this confusion diplopia arises, the eye would try to adapt to it by undergoing some adaptations. So there are two types of adaptations which the eye tries to do, or the eye and the brain both try to do, is suppression and is the sensory adaptations and the motor adaptations. So sensory adaptations would be suppression or ARC. Suppression will happen when there's a large amount of deviation because ARC is a positive adaptation which allows for some degree of binocularity. So that will happen only when there is a small degree of deviation. Otherwise, the eye will tend to go into suppression. Suppression does not allow any degree of binocularity. So it is a harmful sort of adaptation. And what are these terms which I mentioned? The monocular, the alternating, and the facultative or obligatory. I'll just try to explain by these diagrams. In monocular, only one eye is being constantly suppressed. Other eye is always acting as the dominant eye. So this is a very, very strong stimulus for amblyopia development. While in alternating, the two eyes are freely alternating in terms of one eye is becoming dominant, then the other eye takes over. So this freely alternates. As a result, amblyopia is unlikely to develop in these cases. While for facultative, this will happen only when the eye is deviated. So when there is no misalignment, there will be no suppression. So this is a facultative suppression. And this is usually seen in the cases of intermittent exotropias, or IDS as we call it. While obligatory suppressions is when the suppression is constant at all times. So all constant tropias will tend to go into suppression, which is an obligatory suppression, again, which is a very strong stimulus for amblyopia development, if not corrected. Second thing, sensory adaptation, which I talked was the abnormal retinal correspondence. Now, in this case, what is happening, the fovea of your one eye, which is the normal eye, is becoming corresponding point to a parafoveal point of the deviated eye. So as a result, some quality of binocular vision is able to, a patient is able to achieve some quality of binocular vision, although that is of a lower grade than what is normally there when there is a bifoveal binocular vision. This will develop only, as I told you, when there are small degrees of deviations, which is usually less than 10 PD, so characteristically seen in the cases of microtropias. It will occur only in early onset squints because you have to have a good plasticity of your neural system for this to develop, and a constant angle of deviation. So usually does not occur in paratic squints of large degrees. Then we have the motor adaptations, which is fusion and compensatory head posture. So fusion is again basically a balance between your fusional convergence and your fusional divergence. And it is a critical step which helps the two eyes to fuse the image into a single object. And this fusion is very important because there are lots of patients who have heterophoria, but they are able to keep their heterophoria in control because of this fusion, which is happening at all the times. Compensatory head posture is something which, as I said in the beginning of my talk, that it usually is seen in incompetent speech, especially in paratic squints. And what his head trying to do is trying to bring the eyes to the position where their alignment is the best, so as to avoid diplopia. So head will turn where eyes cannot. Primarily, this is seen in children where have considered abnormal eye movements who are not able to express that they have diplopia, so they do not have, and they tend to adopt a compensatory head posture, or as I said, in recent onset paratic squints, even in adults. So there are three directions which the compensation take place, as I said, based on the muscle which is paralyzed. Either they can be chin elevation or depression. They can be face turn to the right or to the left, or they can be head tilt to the right or to the left. So let's take the example of left lateral rectus muscle paralysis in this case. Now what is happening in this, the eyes cannot move to the left. So there is a limitation of levoversion in this case. So what is happening, the dextroversion is the position where the eyes are maximally aligned. So now the head will turn to the left side, that is towards the direction of the action of the paralyzed muscle, so that the eyes remain in this dextroversion, and obviously the diplopia is minimized. Similarly, for hypertropias or vertical deviations, if there is a weakness of the depressors, as in this case, this left eye is hypertropic, so obviously either the superior oblique is not working or the IR is not working. So in these cases, obviously the eyes are maximally aligned when the patient is looking up. So obviously the position adopted would be a chin down posture. While similarly, if there is an elevated deficiency, it would be a chin up posture. However, in the cases of vertical tropias, also there is an effect of movements on the lateral gaze. So adduction and abduction also have a role. So let's take this example. Now what will happen in this case, there is a left hypertropia. Now if the patient is trying to look towards the right, what is happening is his hypertropia is increasing on adduction of the left eye. While on abduction, that is on the levoversion of the left eye, it is reducing. So obviously in this case, the patient, in addition to the chin posture, he will also adopt a face turn, which would be to the left again, to the right again, sorry. Then the third component is the torsional component, which is a head tilt. Now this is happening when there is a weakness of your intortus or your extortus. So intortus or your superior muscles are intortus. So if there's an intortus of the right eye gone, there will be head tilt to the opposite side. While if your extortus are gone, there will be head tilt to the same side. So this is how the head tilt components comes into play when you have a weakness of any muscles. So let's take the example of left eye superior oblique palsies. So it has all three compensations happening. There is a chin depression with a head tilt or contralateral head tilt and a contralateral face turn. So first thing is, obviously the eyes are maximally aligned in the up gaze. The hypertropia is minimum in the up gaze, so obviously there is a chin depression. Then there is a head tilt to compensate for the extortion of the eye which has happened. To the opposite side, that is a contralateral head tilt. And then there is a face turn to the right side, again a contralateral to the compensate for the hypertropia which will increase in the adduction on the left gaze. So next, I'll be talking about the cover test. So cover tests are done for detection as well as for the characterization of the squint. So there are three components to it. One is a direct cover test, second is the uncover test, and alternate cover test is the third one. So the prerequisite for this, obviously when you see a head posture before starting your test, you have to align the posture back into its normal position. So head should be erect and straight. It should be done, the test should be done both for distance and near. You can start by doing for near. And obviously you have to use a fixation target, whether you're doing it for distance or for near. For distance, you can use a Snell's chart. For near, you need to have an accommodated target. And obviously the occluder has to be there. So what do we infer by these tests? We can infer whether there is a squint or not, if we have not been able to pick up in the Hirschberg. What is the type of squint we can come to know, whether it is just a manifest squint, which will be obvious, but if it is not manifest, by our uncover test and alternate cover test, we can uncover the forias as well. We'll be able to make out the characteristic direction of it. And in cases there is only foria, what is the strength of the fusional vergences, which we'll be able to get a knowledge about that as well as we'll be able to know whether there is a difference between the primary and the secondary deviation, which becomes important when we are dealing with paratic squints. So two questions are to be answered when we are doing a direct cover test. Is there a squint or not, a manifest squint or not? And if there is a manifest squint, what is the direction? So let's take the example in this case by playing this video. So what is happening? There is no apparent squint right now. So I'm trying to cover the left eye. There is no movement of the right eye. But on covering the right eye, you will see that the left eye moved down. So there was a hypertropia which became apparent on covering the right eye. This is a second example where there is already, obviously, there is a squint. So I'm covering the right eye, which is a fixating eye, and then the left eye moves in to take a fixation, indicating that the left eye was in exodeviation. So same thing, I'm demonstrating with the video. This is a cover test, again, which is showing, I'll just take it faster. So there's a normal ocular alignment. On covering left eye, there is no movement of the right eye. So when we are doing the cover test, we are observing for the movement of the other eye. So there is no movement when you're covering the left eye. Similarly, when we are covering the right eye, there is no movement. So obviously, the eyes are aligned. So there is no manifest squint at this stage. There could be other reasons for this also, but I'll let you know what are the reasons. Now, let's take a case of esotropia. Now, the left eye is already in inward deviated. So now we're covering the right eye, that is fixating eye. So what happens? The left eye moved out to take a fixation. So when we shift the cover to the other eye, obviously the reverse would happen. Now this is a case of exotropia. Now the left eye is again already in a deviated out position. Now we are covering the right eye, the fixating eye. So what is happening? So the left eye is moving in to take a fixation, indicating that there is already a left exotropia in the patient. So what do we infer by this direct cover test? So when we are what we are doing in the direct cover is we're covering one eye and looking at the opposite eye. So movement of the other eye is being noted. If there is a movement noted, obviously there is a manifest deviation. But if there is no movement, as I said, either the patient does not have any squint, no manifest squint, or there is a bifoveal fixation, but there can be that the patient still has a foria, or the patient has a apparent pseudo squint when there is no movement. Sometimes, even in the presence of manifest squint, there can be no movement. So what are those scenarios? It means that vision of that patient's eye is very, very poor. He does not have any significant vision. It's almost a blackly blind eye. Or there is a total acute onset paralysis where the muscle is not allowing the eye to move at all. Or there is a gross eccentric fixation. So in all these cases, even in the presence of manifest squint, when we are covering the fixating eye, the other eye may not show movement. So once we've done the test for one eye in the covering one eye, then we repeat the same test for the other eye. So this is how the direct cover test is. Now let's shift to the next component of it, which is the uncover test. Now there can be two scenarios when we are doing the uncover test. In the first step, which is our cover test, we have a situation where we have a manifest squint was not there. So which means we could be dealing with a case of either a pseudo squint or a latent squint, which is heterophoria. So this test will now help us to uncover an heterophoria, as well as it will help us in assessing what is the strength of fusion of the heterophoria. However, the second situation is when there was already a manifest squint noted in the step 1, that is in the cover test. Now, this step, in addition, will help us in knowing whether there's a true alternating or a freely alternating squint, which is the manifest squint as detected in our step 1, or is one eye dominant over the other eye. And also, it will help us in knowing is the primary deviation equal to the secondary deviation or not. And for 4 years, it will, as I said, it will help us. So I'll just, again, go with the video with there. So we're covering the left eye. So this is sort of a Spielman occluder. You can see underneath it. Otherwise, you can use preferably would be a Spielman occluder, but otherwise, you can always use a total concrete occluder as well. So what is happening in this case? So apparently, there is no squints. So there is a step when there is no apparent squint on a cover test also. So what we are doing when we are covering the left eye in this case, so what is happening? The eye is moving in, which means there is an element of exophoria, which as soon as the cover is taken off, it comes back to its normal position. So the speed, which I said, the speed with which it covers will help us in knowing what is the strength of fusion. So if it is coming with a slow speed, obviously it is a bad prognostic factor. If it is coming, which has a higher chances of decompensation and going into a manifest squint. But if the speed of recovery is good, then it shows the patient has a good binocular fusion potential. So next is the alternate cover test. So we have already made a diagnosis with the cover and the uncovered test, whether it is a manifest squint or is it just a latent squint. Now, alternate cover test will help us in breaking the entire fusion, complete fusion, will completely dissociate the binocular vision of the patient and will help in detecting the total amount of deviation which the patient has. And sometimes in young patients, even by an uncovered test, we may not have been able to break the phorias. So performing this alternate cover test in quick, rapid succession will help us in breaking this and picking up the phorias, which might have been mixed because of the strong fusional amplitudes in children. So let's look at the video here. So obviously, we are shifting the cover from one eye to the other in quick succession and looking for the movement of the eye which is not covered. Obviously, the eye which is covered and the other eye which is not covered is to be looked at. So at the end of the thing, if there is a decompensated heterophoria, the eyes may become a phoric or a latent squint may manifest at that point if the strength of fusion is not very strong after the alternate cover test also. I'll skip this video because it's the same thing which is being shown on a patient. So the primary deviation, secondary deviation, I think everybody understands what is primary deviation and the secondary deviation. So just remember that concomitant skin, primary deviations would be, as we said in the beginning of the lecture itself, the concomitant skins, your primary deviations is equal to secondary deviations. It is the same in all directions of gaze, but that is not the case with parietic squints, where secondary deviations, when the parietic eye is fixating, are much more than when the non-parietic eye is fixating, so which is the case in the parietic squints. This I'll skip through because of shortage of time, because I was trying to think of summarizing. But now let's go to the next step, which is the measurement of squints. So in children, sometimes may have to resort to the Hirschberg test itself for measurement, very, very young infants. Otherwise, we have the main test, or the Prism bar cover test, which is the most accurate test. But the Krimsky reflex test, when do we need to do that? I'll talk about it in my subsequent slides. So as we all know, Hirschberg test is to be performed at a distance of 33 centimeters with a pen torch shining at your glabella. And every 1 minute of deviation is equivalent to 7 degrees, equivalent to 15 PDs. And this, as I told, may be used as a measurement test for measuring the deviation and to do your surgeries sometimes, especially in very, very young and uncooperative patients, when fixation of the deviating eye is very, very poor. And also, it has an advantage that it helps in excluding pseudostrabismus. But the main thing which we have to use, or the main test which we have to do for measurements and for planning a surgery is the Prism bar cover test. And where alternate prisms of increasing strength are placed in front of the deviating eye or the other eye. I'll tell you what are the two types of Prism bar cover test. With the apex in the direction of the squint based on the presence of prisms, how they work, until no movement of the other eye is observed or on alternate covering. So the advantage of this test is it does not depend on the position of the corneal reflex. It depends on the movement. So that's why it gives you more accurate measurements. But the quality of the prisms has to be good. We need to do it again both for distance and near. Again, head has to be looking straight and erect. It should be erect. full refractive correction should be worn by the patient. This is especially important when we are testing for accommodative and partially accommodative esotropias. And we have to measure in all positions of the gaze to pick up any patterns, as well as to pick up any secondary deviations, as I said, which may be more in the cases of paratic squints. Practically, when you're using prism bars or which are plastic prisms or loose prisms, remember they have to be held parallel to the plane of the orbit. That's very important, otherwise it will induce an error. While glasses prism, which are the ones which are available in your trial frames, are to be held in the Prentice position. So that's important. Do not tilt your prisms while you're holding, otherwise you'll be doing wrong measurements. So as I said, there are two ways which you can do your prism bar cover test. One is a simultaneous prism bar cover test, where obviously you're putting the prisms in front of the one of the eyes, apparently straight eye, and measuring the deviation of the movement of the deviating eye. While in alternate prism test, you're alternating the putting the prisms in front of one of the eyes, fixating eye, and you're alternating the cover and looking for the redressal of the uncovered eye. Remember, this cannot be done if the patient has an eccentric fixation or is blind, has low vision. As I told you, you have to make the patient wear the refraction if you have high refractive errors. But remember, there are effect of the glasses being induced on your measurements. So high plus lenses will underestimate, while high minus lenses will overestimate your readings, your measurements. So you have to take care into calculations while operating on the patient. And in competence and competence, as I already mentioned, you have to measure in all cases to pick up for that. So let's take this video where we are doing the measurements of a case of left esotropia. So obviously we are doing an alternate prism cover test and keep on gradually increasing the prisms with the apex placed towards the, with the apex in on the left eye. We're gradually shifting the cover from one eye to the other and gradually increasing the strength of the prisms, as you can see in this. So the point on utilization would be one when obviously you do not see any redressal movement. You can go add another five prisms over it to see for the reversal of movement and then come back and again check for the neutralization point. I'll skip this video again. This is a repeat of that. So then when we are not unable to do the prism bar cover test is the time when we resort to the prism bar reflex test or the Krimsky's test, which are both based on the corneal reflections and can be done, they again should be done for both distance and near. In Krimsky's test, we are placing the prisms over the fixating eye, while in prism bar or the modified Krimsky's test, we are placing the prisms in front of the deviating eye. That is the only difference. But what we are supposed to neutralize in these cases is the corneal reflection. So by increasing the strength of the prisms, we try to bring the corneal reflexes of both eyes, try to make them symmetrical. And that is the endpoint. So this is the Krimsky's test. So again, this is a video which shows the Krimsky's test. So obviously, we are not doing any looking for the movement of redressals. We are just looking at the corneal reflex in each eye and continuously increasing the prisms of increasing strength till the light reflex becomes symmetrical. So next thing, important thing is to assess the ocular motility. We have to do versions, deductions, if required, the saccades and the convergence. Now, I've just given this overview and just look at the dotted lines, which is actually the direction of the maximum action of that muscle. And that is a position where we test that particular muscle. So that is important for all of you to remember. This should be remembered for when you're doing this should be there at the back of your mind whenever you're testing any patient with a strabismus, when you're checking his motility. So obviously, all the patient is given strict instructions again to keep the head straight and follow the target without moving his head. So that's important, follow the target. So this is the video which is showing that. So basically, we are asking the patient to look in the different directions. Always try to bring the target back to the midpoint before taking it to another direction. So for example, if I'm checking for dextro versions, I'll come back to the primary point, go to levo version, then come back to the primary point. Same way, while I'm checking for the elevation, go up, bring back to the primary point, then go down. Same way for dextro elevations and dextro depressions. So any of the directions, you have to go back to the primary point or the primary fixation point and then go to the next direction. So what all can we pick up when we are doing this extraocular motility testing? Remember, when we're looking horizontal, so horizontally, either we'll be doing dextro versions or levo versions. So remember to look at both the abducting and the adducting eye. So if there's an abduction limitation would be there, maybe there in Sickner palsies, in Duane's, In myositis is the MR. So there will be multiple conditions. At the same time, look at the adducting eye also. So adducting eye on the other side. There may be adduction deficit. So then the diagnosis should come into mind is what should be a diagnosis which come to your mind? You're making the patient do a dextroversion and you see an adduction lag in the left eye. So what thing should first strike you? INO. So that's why you have to look, when you're doing horizontal movements, look at both the abducting and the adducting eye, okay? Similarly, while you're doing the vertical movements, you have to look for what all thoughts should come to your mind. So it should be a third nerve. So obviously superior movements are gone, so third nerve could be involved. It could be supranuclear gaze palsy, so supranuclear lesions. It could be a limited pathology. It could be restrictions coming because of thyroid pathology or because of blowout fracture and trapping the muscles. Or at the same time, you also look up to patterns. In cases of competent squints, also we can have pattern forming, especially when we're doing the vertical movements. So either a pattern or a V pattern may be forming in some of the cases. So look for those patterns. Then we have the 4 oblique directions. That is the dextro elevation, depression, levo elevation, and depressions. So obviously, in those cases, it is mainly what you have to look for is the Brown syndrome, where there is a limitation of elevation in adduction and a limitation of depression adduction. The things which will strike you is a superior oblique palsy. So in these cases, you can go ahead when you have a single muscle palsy or a tilt is there, then you can go ahead with a Park-Belchowski's 3-step test. Adductions are to be done when you find a limitation in your versions. Otherwise, it will not give you any additive information. Saccades, as I said, would need to be done whenever you have any supranuclear lesion or a brainstem injury or in Parkinsonisms. So saccades will have to be tested. How do you test for saccades? So a small video showing you the saccades. So test for both horizontal saccades and vertical saccades, which will help in you. Is there any loss of saccades? Are there any asymmetric saccades? So obviously, easiest way is either to use 2 different targets. I use my finger and thumb, give the patient direction to move from finger, very rapid movements from finger to thumb, both holding it horizontally and both holding it vertically like this. So this is the way you test for saccades. This is the test which is important when you have any head tilt or is a torsional diplopia, patient presents to you, or you see hypertropia in the primary gaze. So the 3 questions which are there, or 3 steps of the Park-Belchowski's 3-step test is, which eye is hypertropic in the primary gaze? That is your first question, because that will tell you which eye is elevated, which means the depressors of the eye are not working, or it is the elevators of the other eye which are not working, the eye which is hypertropic. So second thing is which you have to judge is ask the patient to look to the right or to the left. So then you have to judge, is the hypertropia which is you're seeing in the primary gaze, is it worse on which gaze? On the right gaze or the left gaze? This will worsen in the gaze depending on wherever there is a greatest vertical separation of the muscles, greatest action of the muscles. For obliques, as I tell you, remember the primary action which we are testing. For the obliques, this is when the eye is adducted. For the recti, it is when the eye is abducted. So this you have to remember when you're doing the Park's 3-step test. So this will help you in limiting, now cut-shorting, bringing your position, 4 muscles pathology to 2 muscle pathology, okay? And the third step is the tilt test, which is basically Belchowski's step, which is basically letting you know which is the single muscle, which is the paratic muscle. In this, you're asking the patient to tilt the head to the right or to the left, and this is based on the mnemonic, remember this, SINRAD, that is the superior's intort and the recti inferior's extort. So you have to remember that. So let's take the example of this case. This is a right superior, this is a case of left hypertropia. So what is happening? In the right gaze, the hypertropia is increasing, while in the left gaze, it is becoming less. Now we do the third step. So this is what is happening. On the right tilt, it is almost neutralized, while in the left tilt, it is further increased. So this is what is a classical case of right superior oblique palsy. What has happened? This video is not playing, I'll skip it. So the last thing which is supposed to test in the muscle while testing with ocular motility is your vergence. You have to assess the convergence by asking the patient to look at a near target, follow the near target. And because convergence insufficiency is again a feature, it could be a part of a tonic convergences, or it could be convergence paralysis happening in the lesions like supranuclear lesions like Pendular's dorsal midbone syndrome. Sensory adaptation tests obviously are the tests for fusion, which are the Worth-Fodor tests, which everybody should be knowing and should be able to do because most of the Snellen's visual acuity charts have that. So Obviously, what we're doing, we are placing red and green glasses in front, red in front of the right eye by convention, left in front of the left eye, and asking the patient to look at 4 dots, which are there on the Snellen's chart. A patient who has a squint but has developed that ARC, anomalous retinal correspondence, will able to see those 4 dots as a normal person would be able to do it because of the binocular fusion which he has got. But a patient with a right eye suppression will only see 3 greens, while a patient with left eye suppression will see 2 reds, while a patient with ESO or an exotropia would see or a phorias will also see a diplopia. Now, as I said in the beginning of my lecture, obviously in exotropias it will be crossed. So obviously the red eye would have their image projected to this side, and the left eye would have its image projected to this side. While for esotropias, it will be uncrossed. So the right image will be projected to this side, and the left eye image would be projected to this side. Similarly, yeah, I'll just find out this last.
Thank you.
So Bernoulli's striated glasses work in the same way, where the striations, obviously the streak of light is pointed to the with the patient wearing the Bernoulli's striated glasses, and again it gives us the same impressions because the streak of light will spot of light will create a streak of light perpendicular to the striations of glasses, and again we can interpret in the same way as we do for the word 4-dot test. For the vergences, we need to measure both the convergence and the divergence by using the base out or the base in prisms. And I'm just skipping the videos. So you should know the normal range of the vergences for distance and near so that you know what is the breakpoint and the recovery point for the patient. Have they reduced or they have increased? So you have to know that. And finally, you have to test for the near point of accommodation and convergence and AC by A ratios, which become important, especially certain types of accommodative esotropias, which are done by using an RAF rule. And finally, the degrees of binocular single vision you have to test for the stereopsis. So various tests for stereopsis are listed here. I'll not be going into details of that. And finally, as I said, especially in cases of paratic squints, you should serially monitor these diplopias or the patient, to see whether the patient is improving or is developing some other problem or is it worsening, to take your decision when to do surgeries by doing continuous or consecutive diplopia charts, Hess charts, and field of binocular single visions. So these are and finally a fundus examination, as I said in the beginning, to document your any exotropias or intorsions or extorsions which are happening. Thank you.
Thank you, ma'am. Very exhaustive, but if you have a good foundation, everything else falls in line. Thank you so much. It was very lucid and exhaustive. Now, it's my personal privilege to really invite Dr. Rashmin Gandhi, who is very kindly consented to make up because Dr. Suma wasn't available. So, Dr. Rashmin Gandhi, as you know, that he's a pioneer of neuro-ophthalmology, and at present he's attached to CFS Hyderabad, adjunct faculty at IIT Hyderabad, and has been a mastermind at Foresight worldwide. But I think let's not forget that he's one of the founders, of this iFocus program, and I think to be a teacher is one of the biggest assets, anyone can actually imagine. Sir, all yours.
Thank you. Thank you, Sumit, for a very kind introduction. So we're going to talk about nystagmus. Since we have 15 minutes, it's going to be evaluation of nystagmus. I know when we think about nystagmus, when we encounter nystagmus, generally we'll not be very comfortable because it's a complicated subject, and also it's very difficult to evaluate. So I'll try to simplify it as far as possible. So first thing, how would you define nystagmus? I want 4 points, 4 essential points which make the definition of nystagmus. One person, yeah, loudly. All right. Very good. So four building blocks of nystagmus definition: bilateral, involuntary, to and fro, rhythmic movements of the eye. Bilateral, involuntary, to and fro, rhythmic movements of the eye. In this, the last two, to and fro, obviously it has to be to and fro because it's nystagmus, and rhythmic are non-negotiable. There are no exceptions. If it's not rhythmic, it is not nystagmus. It is nystagmoid movements, and there are, again, a host of movements which are called nystagmoid movements. So rhythmic is what will constitute nystagmus. To and fro, and rhythmic. Bilateral, can nystagmus be unilateral? Exception to that, that part of definition. There are 3 exceptions to bilateral rule of nystagmus. Internuclear ophthalmoplegia, you have nystagmus only in the abducting eye, spasmus nutans, and in dense amblyopia, you can have a vertical movement called Hyman-Bilchowski phenomena, which will be unilateral in that eye. If you call it a nystagmus, then there are 3 exceptions to a bilateral part of the definition. Involuntary, well, there are people who can actually generate voluntary nystagmus. So that's a sort of a exception to that part. So define, we said bilateral, involuntary, rhythmic to and fro movement of the eye. Why would you like to evaluate nystagmus? What is the importance of making sure that you evaluate nystagmus in a proper way? Because nystagmus can be the first and sometimes the only sign of a serious neurological disorder. That's the reason why we'd like to evaluate nystagmus, to make sure that you weed out nystagmus which arises because of serious neurological disorder. That's what our job today is going to be. Can we, by looking at nystagmus, come to a conclusion that this seemed to be a neurological nystagmus? Okay? And how we're going to do it? These are the steps. First thing you ask yourself if you see a patient with nystagmus is it present in primary gaze or absent in primary gaze? That's the first thing you ask yourself. Once you have determined that, then you look at the movement of the eye and say whether it's predominantly horizontal, vertical, or torsional, how the eyes are moving. The third part is jerk versus pendular. What is a jerk nystagmus? What do you mean by a jerk nystagmus? It has a fast phase. Pendular nystagmus, the eyes move like a pendulum. There is no fast phase. While a jerk nystagmus, you have a fast phase and a slow phase. So actually it starts with a slow phase. The eye tracks a target which is moving, and then there is a correcting saccade. So even if the target is not moving, eye drifts, correcting saccades. Drifts, correcting saccade. So there is a fast phase. This correcting saccade is a fast phase. And how do you define the direction of a nystagmus? Direction of the fast phase. So if the eyes are moving like this, it will become, how do you say, left beating, is it horizontal or vertical? So left beating horizontal nystagmus. The fourth thing is, what happens when the patient, and this is a very important point, what happens to nystagmus when the patient looks to the right, left, up and down? And there are 3 features that you're looking at. What happens to the movement of the eye? What happens to amplitude? What is an amplitude of nystagmus? How much is the excursion? And frequency, how fast the excursion? So what happens to these 3 when the patient looks to the right, left, up and down? And what happens when patient converges? All right, now I'm going to show you some videos. You have to evaluate those nystagmus, keeping this in mind. So first obvious example would be nystagmus which is absent in primary gaze. Okay? Endpoint nystagmus. So endpoint nystagmus is, the video is not playing. Let me show you if I can. Yeah, here. So this is an example of an endpoint nystagmus. What happens? The eyes move right at the end of the gaze. So there is no nystagmus here. Once he reaches the end of the gaze, you can see that flickering movement. That is an endpoint nystagmus. It is transient. It dies down if patient continues to look to that eccentric gaze. It is transient, it dies down, it is physiological. Endpoint nystagmus, right at the end of the gaze, transient movement which dies down and generally of high frequency. Okay, so first differential, if the nystagmus is absent in primary gaze, is going to be endpoint nystagmus. The second differential, when the nystagmus is absent in primary gaze, is going to be this. All right. Present in primary gaze? Not present. Now, how the eyes are moving? Horizontal, vertical, torsional? Torsional, very good. Again, you can see this, there is a torsional movement, right? So this is the second example of nystagmus which is absent in primary gaze. First we said endpoint nystagmus. Second, this was the torsional. Did you see any difference between this and the previous nystagmus? Any difference? Okay, faster. Anything else? This starts before the end of the gaze. Just see here. You have not reached the end of the gaze. You can still see the sclera, but the eyes are moving. And it's not dying down. If the patient looks there, the nystagmus would continue. You see, it is starting before the end of the gaze, and it continues. This is called gaze-evoked nystagmus. Endpoint nystagmus is physiological. Gaze-evoked nystagmus, you have to investigate. It can be a part of infantile nystagmus, but generally gaze-evoked nystagmus don't leave it. So these are two nystagmus that we need to look at when you say it's absent in primary gaze. All right. Gaze-evoked nystagmus, these are the causes. It can be because of the drugs. In young patient, it can be a feature of multiple sclerosis, and in older patient, it can be a feature of stroke. All right. So first thing, absent or present in primary gaze. Second, how the eyes are moving. Horizontal, vertical, torsional. Please remember, as a rule, if you see any eyes which are moving vertical, they are considered as a neurological nystagmus unless proved otherwise. Unless you can pinpoint that, oh, this is a kid who has a retinal dystrophy, hereditary retinal degeneration, and that's why the eyes are moving, then you say it can. The hereditary or a congenital retinal dystrophy can produce a vertical nystagmus. But otherwise, any acquired vertical nystagmus has to be investigated before you label it as something benign. So vertical. Vertical, two possibilities. If the eyes move like this, how would you say it? Upbeat, because the fast face is to the up. And this is a downbeat nystagmus. So let's see the examples of both upbeat and a downbeat nystagmus. So what is this? Upbeat or downbeat? Upbeat nystagmus. Now I said in between that you also have to say what happens to nystagmus when you converge. Let me show you this. Tell me what do you see? Patient is converging. Now she is looking straight. What happened? It dampened a little bit, right? So that's the importance, and I'll tell you why this is important when we talk about the upbeat nystagmus. So that's the importance of looking at the convergence. You could clearly see that the nystagmus was dampening. Let me also, since the video is not playing, show you one more nystagmus here, if it plays. I'm sorry if the videos don't play, then you can catch me during the lunchtime or break time and I'll show you all the videos. Tell me, what do you see? Present in primary gaze? Yes. Horizontal, vertical, torsional? Vertical. What do you think? Downbeat. There is a clear fast face to the down. See what happens when the patient, effect of gaze. What happened when the patient looked down? It increased. It became much more prominent, right? So these are the examples of upbeat and a downbeat nystagmus. Let's look at the theory. Upbeat jerk nystagmus. In a central gaze, no nystagmus in up gaze. Generally, it will be nystagmus in central or a down gaze. Generally, you will find a lesion in cerebellum or lower brainstem will produce upbeat jerk nystagmus. The patient that I showed you, where the convergence dampened the upbeat nystagmus, had Wernicke's encephalopathy. So one of the features of Wernicke's encephalopathy is where patient will have upbeat nystagmus, but when patient converges, it will be dampened or become downbeat nystagmus. So that's upbeat nystagmus. These are some of the features of downbeat nystagmus. Patient would have vertical oscillopsia. The patient which I showed you had Arnold-Chiari malformation when there is a herniation of cerebellum through foramen magnum. Drugs like lithium can also produce downbeat nystagmus. So that's about first absent in primary gaze. So you can remember as A, B, C, D, E. A, absent in primary gaze. B, bouncing up and down. The vertical nystagmus, almost always pathological. C, pendular. What would cause a pendular nystagmus? What do you think you would be interested in if you see a patient with a pendular nystagmus? This is how the pendular nystagmus looks like. There is no fast phase, the eyes move like this. And what causes a pendular nystagmus? Generally, pendular nystagmus is also called a sensory nystagmus. What do you think this patient is having? This patient is from Tamil Nadu. Albinism. So why would albinism cause a pendular nystagmus? Pendular nystagmus, also called sensory nystagmus, you need to look at the fundus very carefully. Foveal hyperplasia, optic nerve hyperplasia, cone dystrophy, congenital toxoplasma scar, all of them would cause pendular nystagmus. So generally, pendular nystagmus would be because of something happening in the eye, though you should check the palate, because oculopalatal tremor is a condition where there can be a problem in the brainstem, and these patients would have pendular nystagmus and a palatal tremor. So that's C. Nystagmus, what happens to nystagmus when the patient looks to the right, left, up and down? Let's look at this video. I want you to evaluate this nystagmus for me. Present or absent in primary gaze, all that. Okay. Present in primary gaze? Horizontal, vertical, torsional? Horizontal. Okay. Jerk, pendular? Jerk. Tell me what direction it was? Left beating, horizontal jerk nystagmus, present in primary gaze. What happened when the patient looks to the left? Increase in amplitude and frequency. Now see what happens when the patient looks to the right. Almost died down. What do you call it? Null point. This is the other thing now. What happens when the patient converges? Dampened. That's a feature of infantile nystagmus as well. And the other feature which probably I didn't elaborate was that patient had a horizontal nystagmus which remained horizontal when the patient looked up and down. This is called a uniplanar nystagmus. Two possibilities, congenital nystagmus or peripheral vestibular nystagmus. Uniplanar nystagmus is not likely to be a very serious neurological condition. It can be, but less likely. All right, so that's the effect of direction. Infantile nystagmus or a congenital nystagmus, these are the features. No oscillopsia, mainly jerk. It can be pendular. It's conjugate. It will remain horizontal even when the patient looks up and down. Null zone is present, and that's why patient would have a face turn. Intensity would reduce on convergence and increase on fixation. The two examples of disjugate nystagmus where the eyes would not move in the same direction. One eye will do something else, and the other eye will do exactly opposite. Seesaw nystagmus. When would you see it? Optic chiasmal disease. Seesaw nystagmus, one eye goes up in torts, the other eye is extorting. This eye will start going up, and the other eye will go down. So that's why it's called seesaw. There will be up and down movement of the eye. Generally, it's a feature of chiasmal tumor. So to conclude, these are the effects of convergence on nystagmus. Generally dampens in congenital nystagmus, acquired vestibular nystagmus, downbeat makes it worse, and upbeat nystagmus, it may make it better, as the patient that we saw. What are the drug treatment of nystagmus? Generally, this is all initiated by a neurologist, but it's good to know the list that some of the drugs may have some impact on nystagmus. Baclofen, 4-aminopyridine, neurontin, memantine. These all can have some impact on reducing the frequency and amplitude of nystagmus. Thank you so much.
Thank you, Dr. Ashmin, for covering those wobbly eyes. Really, sometimes it really makes you confuse and wobble yourself, but it's such a lucid presentation for the residents. I mean, one should know the types of nystagmus and what you are actually trying to find out whether it's neurological or not. That's the most important part, and that's been covered very well. So any questions and all?
The points that we have not covered, which are more theoretical are, and sometimes not asked, is the various circuits as to why would you get nystagmus. Electronystagmography used to be asked quite often, but now it's gone more into the realm of neuro-otologists. But it's good to know. Just read it up. There are pages which explains as to how to read an electronystagmography.
Thank you. With that, we'll move on to our next presentations. Dr. Dadia is not here, So I would request Dr. Pramod Kumar Pandey to kindly come to the dais for his presentation. He is basically the former director and he was professor at Guru Nanak Eye Center in MAMC. And his areas of interest, as we've seen so many presentations and all, is complex strabismus. So I'll request Dr. Pandey to kindly start his talk on tackling esotropia.
Thank you, Dr. Jasprit, for this, and I would like to thank iFocus team for this invitation. It is always a privilege and a pleasure to share our thoughts on this platform. Now, we have been talking about extensively about nystagmus. I think we get back from nystagmus back to some more commoner problems. And we'll be talking about esodeviations. Esodeviations used to be far more frequent when we were younger. Slowly, exodeviations have taken over, and now they are far more common as compared to esodeviations. And before we get some basic concepts, I would like to clarify before we talk about esodeviations. One thing is that we say that ontogeny always recapitulates phylogeny. So whatever we have, whatever our eyes are, they have been, we have inherited them from our ancestors, from lower animals. So what was initially happening is that we had two parallel monocular visual systems. If you look at, now there is a right eye, there is a left eye, there is a right optic nerve, left optic nerve, they are going down and going to the brain. Now this, the image on the left side shows that they are going straight to the brain. The image on the right side shows that they are crossing. They are fully crossing. Now, what do you think should be happening? Should we have a fully crossed chiasma or should we have uncrossed chiasma? What is your take? Nature always works by feedback. So there is a fully crossed chiasma in lower so-called lateral-eyed animals, as you can see the fish there. They are running in water, they are in ocean. So once they go down, their obliques act, there is an extorsion, and the eyes go down. As they come up, the superior obliques work, there is an intorsion, and there is the elevation. So obliques are more important. So when we got from this lateral-eyed situation to frontal-eyed situation, our eyes moved forward. The chiasma, which was fully crossed, became half-crossed. Now we have only nasal fibers which are crossing. So this has happened because we want to fuse in the occipital cortex. This did not happen in these lower animals. So with this change from two monocular plants to fused binocular plant, whenever there is a problem with binocularity, we go back to the monocular plant. So a lot of features which you'll find in strabismus are basically our resurrection into moving backward into a monocular situation. This is just showing the fish that here the obliques are far more important as compared to recti. As the fish goes down, there is extortion and there is pitch down movement as it comes up, as I told you. Now, here recti are more important and obliques have been put to less use because now we don't want torsion. The role for torsion has gone away. So our problem with binocular single vision is that torsion has to be kept at bay. So with that, do we actually need oblique muscles? In frontal-eyed situation, we don't need them so much, but they are, in fact, you can say they're more of a liability. There are laws like Donders and listings. We'll not go into detail, but they determine that how much torsion can be okay for fusion. If the torsion is more, fusion will be not possible. So it is a difficult situation. Now, one more thing is about these graviceptive pathways. You know, semicircular canals, you know that there is a feedback from these canals to extraocular muscles. So this is happening because eyes and ears work together to maintain balance. Now, binocularity has also ingrained certain amount of balance in this graviceptive pathways. Now, if there is breakdown in binocularity, we go back to those primitive reflexes, and there will be problems with the motility. So if there is a poor cortical wiring in this occipital cortex, or there is failure of wire, one is that it has not happened, like in infantile deviations, and one is that it had happened to some extent, but it has gone wrong, like you can say accommodative esotropias. So if this happens, you will have returned to the primitive monocular system, and you will have conditions like primary inferior oblique overreaction, primary superior oblique overreaction, DVD, DHD, DTD, you understand? DVD is dissociated vertical deviation, DHD, dissociated horizontal, and DTD, dissociated torsional deviation. All these are important because you tend to overlook DHD and DTD. Quite often they are an important parameter. And you will also have a latent nystagmus and smooth pursuit asymmetry. So whenever binocularity has not developed, you can have all these features, or it has failed, all these motility problems can come in. Now coming to ESO deviations, there is a large list. I mean, it can be very exhaustive. So I have just put common important conditions, like you have infantile deviations, accommodative esotropias, acute acquired competent esotropia, sensory esodeviations, consecutive esotropia with myopia and high myopia. Then you have esotropia with cerebral palsy, CVI, and hydrocephalus, and ROP and esotropia, and cyclic esotropias, which are not very common, but once in a while you do see them. Now, when you're taking history, what we need to know, it is important to take a good history because that will give you a lot about understanding about what kind of problem you're dealing with. So you need to look at the deviation, look at any limitation of eye movement. Should keep in mind that it need not be an incompetent deviation to have a limitation. You can also have in competent situations like cross-fixation in infantile esotropias, for example. Any double vision, that can also happen if the deviation is acquired. Any poor vision or any amblyopia, which we need to look at. Any abnormal eye movements in the form of nystagmus, like you may have Ellen in these cases. In past, there has been any history of patching, any spectacle wear, any strabismus surgery, which has already been done, and what was done, which eye, both eyes, or any details. Any other surgery like detachment surgery has been done or cataract surgery has been done, because it may also have a bearing on the deviation, like sensory deviations, we may have them. And if there's any history of prematurity or ROP. Birth weight, prenatal history, all this is very important. HIE, because you can have infantile deviations, both ESO and EXO, in these situations. And what is the motor and speech development, family history of strabismus if it is there, and any consanguinity. So all this is important. Visual milestones, as we know, the child learns to fixate by about 6 weeks of age. So neonate does not fixate. Eyes are in an exo position, quite often in a phoria. And by 6 weeks, he starts fixating. So only after 6 weeks, you will have some alignment of this visual axis. Now, if this doesn't happen, if there is a still ESO or EXO, so then by 6 months, we call it that this is an infantile deviation, either ESO or EXO. So infantile deviations are not present at birth. They are only acquired later. Important thing to keep in mind. That's why we don't call them congenital. Now, visual acuity, we need to keep in mind that we need unaided and aided visual acuity. We also need binocular vision in things like nystagmus, as Dr. Rashmin was talking about some time back. We need to look at near vision, which may have its own vagrancies. Amblyopia, if any. And very important to keep in mind that a good refraction under proper cyclopedia and fundus evaluation is very important. Because glasses will need to be prescribed accordingly, and if we don't have given proper prescription of glasses, then things are not going to work well. Now, when to prescribe glasses? Children have a lot of, a good number of us are born hypermetrope, and there's a process of emetropisation which goes on first by 2 years, and to some extent by 6 years. There's a lot of astigmatism. The corneal power is quite high. The lenticular power is also quite high. Because when we began, we had a spherical lens in lower animals. Slowly, our lens got elliptical. So the power has reduced. So all this, because of that, we have a lot of things which are changing rapidly in children. Now in myopia, I have given you different amount of errors which need to be corrected. If it is less than 1 year, 1 year to 2 year, 2 year to 3 year, and more than 3 years. So you can see that in younger age group, more of the refractive errors need not be corrected. Only if the child is getting older and a lot of astigmatism in these children, younger ones, so you need to ignore that. Of course, about hypermetropia, one thing I want to say, if there is a deviation, then lesser amount of hypermetropia need to be corrected as compared to if there is no esotropia. And accommodative deviations can come even at the age of 6 months. Normally they come at the age of 1.5 years, but they can also happen at the age of as early as 4 months to 6 months. So they could be brushing shoulders with infantile deviations. We need to look at anomalous head posture. It can happen in infantile ESO deviations or because of astigmatism or because of amblyopia, a lot of conditions, or even to dampen the nystagmus, like in infantile deviations, you have LN, and in convergent position it is, there is dampening of the nystagmus, so what is known as Ciancia syndrome. So important to look at it, because if you don't look for it, you will not find it, because it may be subtle and it may be missed. And if you make them straight, the deviation may increase. So, because they are using this posture to control the deviation. Now, HP can be there for many reasons. We are not going into the detail here. About the deviation, I think Dr. Vinita has talked in the morning. We just need to know what is the fixing eye. Is there any primary and secondary deviation? The fixation pattern we need to know. We need to know cover and cover test, PACT, simultaneous prism cover test, PUCT. Reverse fixation test is one thing important. Anybody who can tell us about reverse fixation test? What do we do in this? No one? So reverse fixation test is about DHD. So what we are doing here is that you can have an infantile deviation, let's say which is an ESO, and then you can have a super added DHD. So if you miss it and you do surgery for the infantile, the ESO part, it will go into consecutive EXO. So it is important to look at this DHD and accordingly bring down your surgery, otherwise it will be overcorrected. So this DHD is tested by reverse fixation test. What we do here is that after doing PACT, you occlude the eye for a longer time, like what you do in DVD, and then you will find that there is more deviation, which is very often an exo deviation. You can also have an ESO DHD. So depending upon what extra deviation you are able to uncover after PACT, this is to be taken into account as DHD, which I said could be again ESO and EXO. You also need to look at AC-by ratio, very important in accommodative ESO deviations, because you may have a normal AC-by ratio in refractive accommodative and high AC-by ratio in non-refractive accommodative esotropias, which can again be myope or which could be emetrope and hypermetrope. Movements, as we said, they have been, I think, talked about. Only thing I want to say that if there is oblique muscle overactions and underactions, this could mean that there is a poor binocularity or something like infantile deviations. Not that they are always owned by infantile deviations, but they tell you that there is probably a problem with the binocularity. Smooth pursuit asymmetry, DVD nystagmus, all this we need to see. Now here you can see a inferior oblique overaction in the left eye and superior oblique overaction. For your purposes, this is basically a case of superior oblique palsy in the left eye and Brown's in the right eye. But for your purposes, I put this so that you can see that the left eye is rising in adduction and right eye is falling in adduction. Quite often we like to call it over elevation or under depression in adduction, because we don't know what is the cause for this over elevation or under depression. So it is better to call them as over elevation and under depression in adduction, because there could be other reasons like Duane's, it can again cause an upshoot in these situations. This is showing a DVD. As you can see, the eye is going out because of DHD and also going up. So don't think of DVD just as a vertical issue. There is a horizontal component, which is quite often EXO, but it can also be ESO. And there is also a torsional component. As you know, the eye always extorts as it goes up, and the eye which is fixating intorts. Now, sensory evaluation has to be done, like fusion stereopsis, what we were talking about, acquisition of binocularity, and suppression amblyopia and monofixation syndrome also has to be kept in mind in these cases. Torsion, another important thing, you should know that the fovea disc relationship is with lower one-third of the disc, the fovea is located somewhere, but if it is disturbed, then you have abnormal torsion. Important to look at it because it may give rise to failure of your alignment and lot of issues. So like in this eye, you can see the left eye is extorted, whereas the right eye is having normal torsion. Muscle guidance traction test has to be done for obliques. We're not going to the detail. Now, infantile ESOs, as we were talking, these are class apart, important to keep in mind because we have to catch them young and treat them young. If we don't do that, the binocularity will fail and we will not be able to restore it later. So they start by 6 months, they establish. It's not that they start at 6 months, but if you have a large ESO by even 4 months, that needs to be taken care of and operated. So anything which is more than, say, 40 prism diopters at the age of even 4 months, it is unlikely to get back, so we need to operate. If there is prematurity, they are more likely to get low birth weight, Downs, intraventricular hemorrhage, and PVL. All these conditions predispose children to infantile deviations. It doesn't mean that the normal children don't get it, but if you have these, you are likely to get. Now, these are large deviations, freely alternating. There is a cross fixation and face turn and abduction deficit, as we were talking about nystagmus some time back, because they take the eye into ESO position so that there is less deviation. There is pursuit asymmetry. There is manifest latent nystagmus in these cases, and DVD we have talked about, and oblique muscle underactions, overactions. Now, there are many functional deficits in infantile deviations, like absence of motor fusion, absent polar stereopsis, as we talked about, alternating monoocular suppression. There is subnormal VEPs and asymmetric monoocular tracking. This shows that in our country, a lot of infantile ESOs don't get operated. They grow up, when they want to get married, they come to us, and they are operated, and ultimately they become two parallel monoocular visual systems, as we were talking about the fish and man. So important to stress that it has to be caught early and operated early for normal single binocular vision and stereopsis. Now, non-surgical treatment in this case means prescription of glasses, because some of these will also have an accommodative component. Important to correct that, as we said some time back, depending upon the error and age, we have to decide that. Occlusion therapy for amblyopia, very often they are not amblyop because of the deviation, but because of anisometropia or astigmatism or other reasons. Could be contaminated by DHT and accommodative component, as we said. Now, second important thing is accommodative deviations. Age of onset, as we said, could be from 4 months to about anytime 4 years, but the most common age group is 1.5 years. So about 1.5 years, they will have accommodative esotropia. As we said, it could be refractive or non-refractive. Initially, they are intermittent deviations, and later on, they may convert into constant deviations if they are not looked into, and they are prone for amblyopia. Because quite often there is some anisometropia, and the eye which is anisometrop is more prone for going into amblyopia. You will also have inferior oblique overaction, which will come in. Rarely, you may also have a DVD. So these things can happen because the binocularity, whatever had got established, has got broken down, and we are reverting back to monoocular system. So in refractive accommodative, you know, there is a good binocularity. There could be anisometropia, I said, and these things could be happening along with this. This is showing a young child. Parents were very concerned. Eye has suddenly gone in. Obviously, parents are worried what has happened. So they can present in an acute way, and obviously they will not complain of diplopia young children. So always, first thing you need to do is good refraction under atropine. This is showing partially accommodative. If you don't correct the children at young age, and if the onset has been rather early and young, they will become partially accommodative. What is meant by partially accommodative? That some component of the ESO deviation is corrected and some is not corrected. So now the part which is not corrected by the glasses will have to be treated surgically. Now, what is corrected by glasses, we also have to see that the proper refraction has been done and proper glasses have been prescribed. Because quite often the glasses which child is using are not appropriate. He is using lesser dioptric power and is having this. So, important to look at the refraction again. This is another child, you can see. So, very common in our country. They don't bring early and they go into partially accommodative. Non-refractive accommodative, as I said, could be either hypermetrope or myope or emetrope. The AC by A ratio is high, so that gives rise to deviation. And this is more at near, mostly at near, and we need to give bifocal glasses in these cases. There could also be hypoaccommodative convergence excess, and as I said, this could be undercorrected hypermetropia. And you could also have an underacting bilateral superior oblique, if you have. That can also give rise to ESO in primary position and more in down position, which may look like a accommodative ESO deviation. So, important to look at motility in these cases. Treatment is glasses, of course, amblyopia part very frequent, so one has to look at it. Bifocals, contact lenses, myotic drugs, and orthoptics and surgery, of course, for the partially accommodative element. This is another one, acute acquired competent esotropia, which we have seen during the COVID epidemic, that they were okay with a lot of near work and those issues they got into and ESO deviations. And this one we had to operate, and it was okay, bilateral medial rectus recession. It was. Now, some of these acute acquired competent esotropias can happen after neurological disease. You can have CNS tuberculomas, you can have brain tumors, you may have hydrocephalus, so a lot of conditions in CNS which can give rise to acute acquired competent esotropia. Whenever you have this, I think you should always keep in mind that you could be dealing with a neurological problem, and if you are not finding a reason, then always subject them to neuroimaging, and once in a while you will find a CNS lesion. This is showing diffuse tuberculomas in this child. This one you can see is large ESO, which was acquired, 8-year-old child, and he had these diffuse tuberculomas in the brain. Mostly these are in the cerebellum, which is causing these ESO deviations. But in this one, you had diffuse lesions. He also had abnormal torsion. Some more slides have gone away. This is esotropia with high myopia. Here, myopia can give rise to esotropia in a lot of ways. We're just talking about this one because here what is happening because of the staphylococcus formation, the SR is getting pushed medially and LR is getting pushed inferiorly, and IR medially and MR up. So this is what is called as heavy eye syndrome, and we have to do a myopexy for this. Very important to keep in mind, because if you do MR recession, it's not going to work in these cases. So there is also sagging eye syndrome, which is because of the problem with the SR and LR band, which can also give rise to what is known as divergence palsy. This is esotropia with high myopia with ROP. ROP is known to give rise to prematurity, ROP, and ROP with treatment all can give rise to high myopia. And here myopia is not because of the axial length elongation, it is more because of the anterior segment issues in these cases. So all kinds of prematurity, ROP with treatment and without treatment can give rise to different types of, different amounts of high myopia. And if you have treated with laser or with this thing, anti-VEGF, the laser ones get more of myopia because this hypermetropic defocus is taken away. This is with cerebral palsy and CVI. These are again very difficult situations, and a lot of times you have, they are dyskinetic strabismus, that they are at times going into an ESO and at times going into an EXO. So we need to assess them more than once and then accordingly take a call on them. So very difficult situations, a lot of other involvement in these cases, both ocular and systemic, like you may have optic atrophy and a lot of issues, so complex matters. This is showing one sensory esotropia in congenital fibrosis of extraocular muscles. As you can see, he had a cataract operated in the left eye, and vision is very poor, so he has got into a sensory deviations. Otherwise, also the CFUM patients can have an ESO or an EXO because they are basically fibrosis syndromes. Cyclic we see once in a while. I didn't have one ready picture, so I didn't put. Botox can be used in these cases, like infantile deviations and other situations. Otherwise, it's mostly for the incompetent ones. And the surgical management will, by and large, will require bilateral MRI sections up to 6.5 to maximum 7. Don't exceed 7, because earlier they were doing 8 or more when we were younger, and they end up with consecutive exo. So now we don't exceed 6.5 or 7. You can also do bilateral LR resections up to 8 millimeters, RR in one eye, that is MR6 and LR8. You can do 3 or 4 muscle surgery. Of course, surgery for the DVD, primary inferior oblique overaction, will be required. Some of these cases you have operated for infantile deviation, and they are okay as far as the horizontal part is concerned, and they may develop a DVD and primary inferior oblique overaction later, which may need to be treated. Then, of course, if there is surgery for nystagmus is required, that need to be done. So to conclude, esotropia enjoy diverse presentations, less common than exodeviations, and early diagnosis and treatments are crucial in these cases. Thank you.
Thank you, sir. It's always a pleasure to learn from you. Any questions for Professor Pandey?
I think important message was that if you have a primary inferior oblique overaction or DVD or latent nystagmus, always think of an infantile deviation kind of situation, because that means that we are going into primitive monocular visual system. I think that's important, and there will be poor binocularity, and prognosis is going to be bad. So catch them young and treat them young.
So I think we can have a panel discussion at the end. We'll just take your opinion in a while, sir. Please. Thank you, sir. Thank you very much. Now it's my personal privilege to invite Professor Jaspreet Sukija. Sir, please. He's a professor of ophthalmology in PGI Chandigarh, and he's been also one of the mentors and pioneers, of strabismus in neuro-ophthalmology. So this morning we'll just want to learn about exotropia from Professor Jaspreet Sukija.
नहीं अभी ये बंद है ना बंद है तो ऑन करना होगा तब वापस कर देगा स्लाइड गलत है पिछली स्लाइड अब ऑफ है ये ऑन है वॉल्यूम बंद करना है बंद कर लो बंद हो गया ठीक good morning everybody. We've had a lot of strabismus today, and yeah, something as you're discussing with Dr. Sumit, that obviously it requires skills rather than just getting investigations for maybe the other glamorous part of ophthalmology, that's getting an OCT or FFAs and all. So this requires a little bit of brains, and that's why it sometimes becomes difficult in children when you're examining them and they're so uncooperative. So, but yes, one should know, because obviously the children have to go on, lead, they have their lives, they have a number of years to live, and you should be giving them the best vision they can. And so let's start off. Can anybody answer what's the resting phase of the eyes? Have you ever seen when a child is born, or maybe what happens when a person dies? Exo? Exo or iso? Yeah, so what is the direction of the orbits? Divergent? Yeah, so why aren't the eyes divergent? Then they should follow the orbits. Why are the eyes straight? So what is king here? Some word, which one word is the king? Fusion, absolutely. And what are the types of fusion? Anybody? क्या क्या होते हैं? Convergence, what types of convergence? Fusional convergence. Okay, what else? Proximal convergence. What else? Tonic convergence. One more. So because we are discussing exotropias, and obviously fusion is one thing. The moment the king loses power, you start developing an exotropia. Accommodative convergence. Okay. So let's start off with how you're going to see these exotropias, and then what is the best possible management option. So how I'll be covering this is कहाँ से चलता है pointer?
Professor Sukhisha, can I request you to use the pointer because
yeah,
it's an
that's-
online thing also. I mean,
that's what I'm
on the laptop.
Acha, okay, yeah, okay, fine, yeah. So that's fine. So yeah, so that's how I'll be covering exotropias. Actually, they are primary and secondary. Remember that. So primary would be intermittent exotropia, which is the most common. You can have infantile exotropia, which is rarer as compared to an infantile esotropia. And you have specific entities which could be associated with Duane's retraction, third nerve palsy, certain craniofacial abnormalities. So I won't be touching on those because there are different subsets. So our main focus is going to be on intermittent exotropia. So that is what we are going to cover. Intermittent means occurring sometimes and the child is straight on maybe other occasions. So what's the terminology? Do we use exotropia or use divergent squint or use convergent squint? So it's a different terminology used in different countries. So probably in Europe they would say a alternating divergent squint or a convergent squint, or you have a latent squint and a manifest. In maybe US they would say he has an esodiviation or an exodeviation, and they would say exophorias and esophorias. So I mean, basically mean the same thing, whatever they are comfortable with, they use it, and what they're used to rather. So just to cover a little bit of basics before we go on to the practical aspects, probably because obviously mostly postgraduates and you have to give your exam, so we'll just cover a little theory and then go on to the clinical examination. So what are the bases of exodeviation? So it's an assumption that the divergence is an active process. So they thought that divergence is active rather than relaxation of convergence. So this theory is not really accepted because having a divergent process is not really possible. If you just see, can you just diverge your eyes actively? No, but you can converge them. Belchovsky's concept says that is anomalous position of rest contributes to exodeviation. It's true when you lose fusion, okay, which is seen in sensory exotropias. But currently, it's a combination of both and mechanical and innervational factors which come into play depending upon the type of deviation, the cause of the exodeviation when you have one. So we are going to see what is, it refers to the the classification here is referring to primary deviation, not the sensory exotropias. So the it could be either a difference in near deviation versus a distance exotropia. And all depends upon the state of fusional control. So the classification is, some have described it based on the angle of deviation at near and distance. Others have described it based on fusional control. Basically one and the same thing, one leading to the other. And the others are primary versus secondary deviation, which could be paralytic. Now most of these exodeviations are 10 to 15 prism diopters smaller at near fixation because of the influence of fusional convergence. So fusion is very strong at near, especially in children when you're seeing, because mostly these are children who come to us and fusion is very strong. So once you have a strong fusional convergence, obviously possibility of a near exodeviation is going to be much less. And so an increase of more than 10 prism diopters is usually considered significant when you're dealing with distance and near disparities. So just to share with you the classification which is routinely used and which you should know is the Burian classification. He has classified them based on the deviation at near and distance and using, you can say, a gauge of 10 prism diopters. So what he calls divergence excess is when you have an exodeviation at distance which is greater than near by 10 prism diopters. Okay, so a distance deviation is greater than near by 10 prism diopters, called it divergence excess. Then you have a convergence insufficiency. Convergence insufficiency means that obviously the fusional control is gone for near, so the deviation is much larger for near by 10 prism diopters. Then you have a basic. So the distance deviation is same as near deviation, which would be very easy to pick up when you're doing a prism bar testing. And then you have a simulated divergence excess, which is very important to identify because your surgical management is very important in such cases. So initially what happens is when the patient comes to you, obviously the fusion is so good that the distance deviation is more than near. But then you have to do special testing to identify whether it's a simulated divergence excess or not. We'll be covering that in the ongoing slides. So this is the Burian classification of intermittent exotropia. Now you have the Kushner's classification. So as I told you, I mean, depending upon the deviation, whether it's for distance or near, the Burian classified, Kushner classified as based on fusion. So a basic was when he had a near deviation equal to the distance. So ND is near deviation, D is distance deviation. tenacious proximal fusion is what you call as just simulated divergence excess. Okay, so your distance deviation is more than near deviation, but it becomes equal after 60 minutes of occlusion. So that is what is happening here, which is the simulated divergence excess, where the initial distance deviation is more than near, and Kushner then classified this because of a tenacious proximal fusion. That tenacious means not easy to dissipate. It won't go away easily, so that's called tenacious. So there's a strong proximal fusion. And then you have high AC by A ratio. That is, obviously, the distance deviation is more for near deviation and a high AC by ratio is present. Then you have proximal convergence, where you have distance deviation more than near deviation even after 60 minutes of occlusion. So the fusional convergence is gone. It's because of the proximal convergence, with everything is normal, a normal AC by A ratio. Then you have a high AC by ratio, a low AC by ratio, where the near deviation is much more than the distance deviation. So these are different concepts which you should know: high AC by ratio, low AC by ratio. So if you have a high AC by ratio, obviously you will have a better control for near. If you have a low accommodative convergence by accommodation ratio, it will be a near deviation much less as compared to a distance deviation when it's high. When it's low, you will have more exotropia. And fusional convergence insufficiency, again, it's fusing for near. The patient is unable to fuse. Again, you're going to have a near deviation more than distance deviation. And a very rare thing is pseudo convergence insufficiency. It's a very rare thing. So probably does not require that much importance. So here you come, what is intermittent manifest exotropia? What is it? So it is, again, you can see here in the first picture, the eyes are straight. You can see the reflex, it's almost in the center. But when the child starts to look at the distance, or when you break fusion, what is happening here is, you can see there's an exotropia coming on in the right eye. So what's happening here? The child is fusing when the child is seeing for near. And when the child sees for distance, when you break the fusion, just have to play it again probably. Yeah. So if you see that exotropic eye there, and now it's moved in to take up the fixation. Again, it's moved out if you see the right eye. So that's what happening for distance. So this is what is intermittent exotropia. Many times the parents would come in and say the child has a deviation, and when you're examining there, you feel that no, there's hardly any deviation. So this is what has to be done. It's always examined for near and distance, because this deviation, because of the strong fusion which comes up when the child is seeing for near, and always have a good target when you're testing. A torchlight is not really a very good target to test for any kind of a near deviation. So when the child is seeing for distance, the child is suppressing, as was covered in the other slide. So this is what you call a facultative suppression, basically what the child has. So when the child is seeing binocularly, it's suppressing. Uninocularly, the child can see everything. So that's what happens in a manifest deviation for distance in intermittent exotropia. So this is again another patient. If you see here, what's happening here, the eyes are straight. He's looking right and left, fairly good excursions, up and down gaze. But when he tries to see distance objects, this is what happens. You can see the right eye, it's such a large deviation which is coming up. So this is what happens. You break the fusion, and you have a manifest exodeviation. Again, when the child is, you can see a patient is inattentive. Whenever there is the fusion is lost, when the patient is sick, or when you are awakened from sleep, when you're tired, and even in bright sunlight. So there would be deviations coming up during these conditions, because your fusion is being affected. So you can see here in the left, in the photograph on the left, the eyes are straight, but the moment the patient tries to see the distance, you can see there's an exotropia coming up in the left eye. So these are the stages through which the intermittent XT passes usually. So first, what you have, so it's usually exophoria at distance, and orthophoric at near. So the child is really asymptomatic. Okay, so nothing happens. So in the initial few years, this is what is happening. So maybe exophoric at near. So all those who would develop intermittent XT would be going through these phases. Obviously, parents would not notice these things. Child doesn't complain, because obviously if one is he's a child, and secondly because just exophoria for distance. Then it's intermittent exotropia for distance, and orthophoric or exophoric at near. So the deviation starts to come at distance. Now the fusion is taking, it's for near, you have good fusion. So child becomes symptomatic for distance, just tries to close the eye. Then there is exotropia for distance and aphoria or an intermittent XT at near. So here what happens is the child would have binocular vision for near, but the suppression starts developing for distance. And the last stage is, the manifest stage is both exotropia for distance and near when the child loses the binocularity. So these are the stages through which it passes, and that's how you have to know it, because the onset is in childhood. Remember that. So it's the intermittency starts in childhood, and it starts manifesting as the child grows older. There is usually absence of symptoms unless when the child is tired or sick, this deviation starts to appear. And why? Because what happens is, as the child is losing fusion, the child starts to close one eye. So the parents would tell you, okay, fine, what is happening is the child is closing one of his eyes when he goes outside. So that one is it's very important to examine this condition when the parents report such as symptoms, because it's dazzling. The child has photalgia. Okay, he's losing fusion, and that is why, in order to avoid what they say a double vision, the child starts to close his eye. So this uniocular closure happens in bright sunlight. So amblyopia is rare. It starts as an intermittent deviation. So probably you would not have an amblyopia, which is more common in esotropia. You have good binocular vision and stereoacuity for near. There is suppression for distance when it is manifesting. Usually can have a panoramic visual field. The one eye straight, the other eye goes out. So you have a panoramic field because suppressing one eye. And of course, when you have to manage these patients, probably you can just place them into one of the categories of Burian or the Kushner's classification. Things have changed over the years when they say the management probably, if you have to do a surgical management, probably it does not really matter what you're dealing with, but if you have to start off with a non-surgical management, you have to know all these conditions, but it's very important to decide sometimes what type of surgery has to be done in these patients by testing them for maybe the AC by A ratio. So the accommodative convergence is very important when you have to decide the management of these patients. So how do we start off with managing these patients? First of all, you have to do the cover test as was described in the previous presentation. So start off with the cover test for near and distance. So what happens here is, if the child is, you can say, straight for near, he is manifesting for distance, do a diagnostic occlusion, always. So the important points in intermittent exotropia is do a far distance measurement. That means ask the child maybe to look out of the window for more than 20 meters. So that is how you can say an actual deviation, or maybe the actual size of the deviation would be known. Because sometimes their fusion is so strong, I mean the deviation might not be, they might be hiding some part of the deviation when you're doing a 6-meter Snellen's examination. So in the clinic, you always do a, always do a 1-hour monocular occlusion testing. That's called the diagnostic occlusion of Scooby. The Scooby found it. So it's the Scooby's phenomena, where what happens is when you have exotropia for distance and the eyes are straight for near, so you occlude one of the eyes, what is happening is you are basically removing the fusional convergence. So the moment you remove fusional convergence, do a 1 hour of occlusion. If the deviation manifests for near, that means it's a basic deviation. Basic means when the near and distance deviation is equal. So this is just a table. What you have to do when you see this patient is have a 1 hour monocular occlusion. If there is no change in angle, then you do a +3. So this is just to basically to know what type of an exotropia you're dealing with, just like the stages I had showed. If the near deviation is equal to the distance deviation when you're examining in the clinic, probably nothing to be done. But if you have a difference, as in many of the cases, then you have to start off with these things. Okay, do an patching of one eye for 1 hour. If there is a near change, near angles equal distance angle after patching. So remember, you've patched one eye, removed the patch, but be careful not to allow binocular vision. The moment you remove the patch and allow binocular vision, the fusion would again come back. So just patch it, place an occluder over the other eye, and then start your measurement. So if it becomes equal to the near, then it's a simulated distance exotropia with normal AC by A ratio. That means now it's become a basic exodeviation. But sometimes what happens is there is no change in angle. So then what you have to test is the accommodative convergence. You've tested a fusional convergence by doing the alternate cover test, by the patch test. Now what you do is testing the accommodative convergence. So then you put a +3 diopters and see whether there is a change in the angle or not. So if there is no change in angle, you're dealing with a true intermittent distance exotropia. If their near angles equal distance angle, then it's a simulated distance exotropia with a high AC by A ratio. So this is what you have to know, whether it's an accommodative convergence or a fusional convergence you're testing. So that is how first patch, then maybe a +3 diopter lens. Then when you're doing a version testing, check for lateral incomitance. So the exotropia might be less when the patient is abducting or looking towards the side. The management would change, because here, if you do some kind of a recess resect procedure, it could cause further incomitance. And as I told you, a far distance measurement is very important. So it's a little theoretical in between. So what are the factors to consider in management? Visual acuity is one important thing which is very important. So remember that, always try to do patching if there is amblyopia in one of the eyes, and then get the visual acuity, because visual acuity is very important. Even the first thing is refract the patient. So refraction would give you some amount of control, because you're putting in more amount of accommodative convergence is coming in, which is going to control the exotropia. A control score, again, I mean, it's debatable whether you want to have a control score or not, because parents sometimes, you don't know what control the child is having at home. You're relying on the parents. It might be a large exotropia which is happening maybe just 2 or 3 times a day, or it might be a small exotropia happening much more. You can say the duration might be much more. So it's a difficult answer by the parents, so not really reliable. Convergence is something what you need to test, fusional convergence, accommodative convergence, so that's very important. Stereo acuity is important, distance and near stereo acuity. Again, distance stereo acuity, a number of ways to test as was described in the examination, and the cover test and the amount of exotropia. So these are some of the things, a basic examination to done in intermittent exotropia when you're planning a management. So coming to the control score. Now you have different control scores here. You have this Newcastle control score, you have a Mayo control score. So the different control score which depend upon how much time the duration the child is manifesting at home. So it's a home control, which is, I mean, the scoring is done from 0, 1, 2, 3, plus you can see here there's a clinic control score, plus, and again, for near and a clinic control for distance. So you have to add up all these and see where the child fits in. So obviously this is for your, maybe the theory exams, the written part, that 0 is never notice your deviation. In the grade 1 is like eye closure seen occasionally less than 50%, then you go to grade 2, it's about more than 50%, and about 3 when the parents say, oh, he's having deviation for near and distance. And of course, sometimes you have, in the clinic, again, the child is with you for maybe just 5 to 10 minutes, and you have to again see whether the child is, the deviation is decreasing with the blink, refixating without the blink, or is manifesting spontaneously. So you just add up all these, and then come to a score, what it is. So how do we quantify this control? So what is the scoring system? You know that this is the score what you got. If the home score is 0 to 6, it means good to worse. So that is how your score goes. That is how probably you might need to intervene if you think that a score is maybe 6 or maybe 5 or maybe 7. So that's how you might need to intervene. Again, it's not very reliable. Even in literature, probably people are not really relying on all these scores. Clinic control, again, near 0 to 7 is like good to worse. So it's home score and the clinic control score. In children, it's a little difficult to do the scoring system. Then you again have a Mayo Clinic exotropia score, where again the scoring is done, and it's 0 to 10 goes from good to worse. So one should know this, because if you are asked in the examination, probably yes, you should be able to answer that these are the control scores. And I have the video probably, yeah. It's not playing. Anyway. So the classification of control was given by Kushner also again. It's excellent, is there's no tropia, recoveries. So you have excellent, good, fair, and poor. Again, depending upon the tropic phase and the recovery, whether it's a spontaneous recovery, whether it's with a blink or a change in fixation, or the child is just manifesting it and there is no change with the blink or a change in fixation for distance. So these are just some ways in which your intermittent exotropia behaves, and you can just probably grade it to what type of a control the child is having when the child presents to you. So again, I mean, I would say that yes, your cover testing basically would do a lot of things, because you have to break the fusion, and that is probably the most important part, most important examination when the child presents to you with exotropia. So management of these cases would be, again, refraction in all cases. So the moment you correct the refractive error, sometimes the eyes become straight. So always correct the refractive error. You have anisometropia here, you have astigmatism here, you have myopia here, or sometimes you have high hyperopia. Even high hyperopia, one should give a little amount of correction. So because hyperopia is going to relax the accommodation and it will lead to more exotropia. But then what is happening? The risk-benefit ratio. If you are giving a clearer vision to the child, probably yes, you would do that. So again, depending upon how much to prescribe was covered in the previous talks. So one should first refract the child, give the proper refractive error. You can see here what's happening is the moment you give a refraction to the patient, there is some amount of convergence and the exotropia and the deviation diminishes. So this is the first thing, and to have a good motor control. Non-surgical therapy, you can see what's happening. This is the child above what you see here was having an exotropia here. You can see the intermittent exotropia. So what we gave the child in the second photograph, second video is, you can see here the deviation is hardly there. So we given the child a non-surgical therapy, which is in the form of glasses. So non-surgical therapy can be in the form of minus lens therapy, so over minus. What is happening is, in these patients who are about 8 to 10 or 12 years old, you can try over minus therapy as a non-surgical option for the timing if they tolerate it. So if there are no asthenopic symptoms with a minus class and never go above 3 diopters, so this would help in stimulating some amount of accommodative convergence, and where a patient for the timing can wear these glasses and have binocular vision. So this was just one patient where we gave non-surgical treatment in the form of minus lens therapy. Then orthoptic exercises could be tried in patients basically who have fusional convergence insufficiency, not in accommodative convergence insufficiency. Alternate day occlusion, again, it's one of the ways in delaying surgery. It's a temporary measure. When the patient with intermittent XT comes to you and you start maybe give them, if the patient is amblyopic in one eye, obviously you would do patching in the better eye. But if the vision is same, probably alternate patching, alternate day occlusion in the form of just 3 hours a day could be done as a temporary measure, so that to avoid development of suppression. So Kushner has shown that in some of his patients, he could decrease the deviation by alternate day patching, and some of them did not require surgery as well. But in many of his cases, surgery was required. So it might work in some of these patients, and it's basically a good way to have a non-surgical therapy to start with, because if you start doing surgery in these young patients, 2 to 3 years old, there is a chance that they might land up into some kind of a esotropia or a monofixation syndrome. So do they progress? This is very important. Some do, many don't. I think probably there was just one long-term study which saying about, which had 11 years of follow-up, and they did show that it was static in maybe many patients. So there is a lot of variation in the progression, and what is generally believed, it probably would remain static, and in some it would progress. So it's variable. So what you have to do is obviously follow up these children and test for everything, probably a stereopsis, a distance near deviation. So all these things have to be checked to know whether the child is progressing or the deviation is static. So when to intervene or why to intervene? To restore binocularity. So if it's a deviation which is increasing, yes, you have to prevent the deterioration of control, and in some, a cosmesis would be good. Botulinum toxin, as I said, the surgery is a little bit tricky in these 2 to 5 years, in these younger kids because of the risk of maybe overcorrections. So you can try Botox, and in one of these studied by Spencer, he achieves alignment in 70% at a 1 to 4 years follow-up. So the indications for surgery are poor control of exotropia, which manifests more than 50% of the time. There's a progressive deviation, increase in the size of deviation, there's suppression coming up, and there is severe Esotropia. So these are some of the indications when you might like to intervene. So surgeries, mostly what you see are basic exotropias. By basic, I mean is you have a distance and near deviation equal. You could do a recess resect procedure or a bilateral lateral rectus recession depending upon the type of exotropia. You could change your surgical pattern if there is lateral incompetence. If there's true divergence excess, probably better to do a lateral rectus recession. And of course, if there's an adult, probably you could do an adjustable surgery in these patients where you could titrate the amount of recession in the post-op period. So aim is what? A temporary overcorrection with diplopia in an older child, but or keep the child ortho. In a younger child, better to keep the eye straight, not land up in esotropia. But if the child does land up in esotropia, you have to again reevaluate and plan. So this is very important. Cosmetically, you can achieve a good cure. The functional cure is very variable. So whether the child would achieve good stereopsis is so variable. So it's been 40 to 90% in literature. So observation with correction of refractive error is very important. Amblyopia management is the first step what you should do. Reassurance of the patient, how to counsel them, what is the progressing rate, when you want to intervene, what are the non-surgical options you have to all discuss with the patient. And of course, if the child is losing control, then you have to do surgery. So this is just a summary of the intermittent exotropia. It's one of the most common things. So just a few slides on the primary infantile exotropia. It's much rarer. The onset is before 6 months. It's a large and constant angle. It's basic. You can have a dissociated vertical deviation and inferior oblique overaction. So as I told you, it could be primary, which is no systemic disease. And if you have a secondary exotropia, probably, yes, these are soft signs, a primary infantile exotropia, or you have large angles of deviation, probably with the inferior oblique overactions, or maybe DVD, probably these are soft signs for a neurological disease, which could be in the form of any kind of, you can say cerebral palsy as well, or optic neuropathies as well. So basically, one has to, from case to case, one has to evaluate what you're dealing with. So just to show you some of these examples here, you have this child here with a deviation with the exotropia here, and you can see here what's happening when the child starts to look in liver elevation. So you can see here the eye, just this right eye is going up. So there's some inferior oblique overaction, and if you see the deviation here, you can see there's a difference in exotropia. It's 65 here and it's 40 here. So probably the inferior obliques are causing a V pattern. If you see here, the eyes, what you see here is the eyes. The exotropia is less here, but when the child starts to look up, the exotropia increases. So these things have to be tackled when you're doing surgery for exotropia along with. So management, again, large angles, so botulinum toxin should be reserved multiple times. GA has to be given. So I think better to do a surgery where you know that the results are more acceptable. Aim for slight ESO maybe in 50% as a chance of resurgery, or undercorrection and high in these cases. So the last part is going to be sensory exotropia. So any media opacity resulting in deviation, usually what happens is, as I told you, the resting position is of exotropia. So the eye starts to deviate out, and over time, the angles increase. So sometimes you have a tight lateral rectus syndrome. It's a long-standing large exotropia of maybe 40 prism diopters. There is limited adduction. There is excessive elevation and depression in adduction. You have an X pattern, and you may be having an underaction of superior rectus and inferior rectus. So you should know what a tight lateral rectus syndrome is. Of course, the management would change if you diagnose such a condition. So the management is treat the underlying pathology in timely manner, may reverse. So sometimes if you have like a child with maybe a pediatric cataract or something, and the child develops exotropia, if you deal with a timely manner, always remove the pathology before doing the surgery for sensory exotropia. If it's if it's an adult, yes, probably you might not, it might not be possible for you to basically correct that by removing the pathology. But for children where you find that, yes, there is something which can be removed, I mean, you should go in for that. Patching for any functional component, again, surgery, probably because these are large exotropias, have a little ESO bias. That means do a little overcorrection, because the tendency for drift is always there. Exodrift will occur in these patients because there is nothing to control. There is no fusion to control the deviation. So that's how sensory exotropia should be treated. So we've covered all these things. The last one is conjunctive exotropia. So you've done surgery for esotropia. So we've just discussed esotropia in the previous lecture. So if you do esotropia and you land up in an overcorrection, probably that has resulted in a conjunctive esotropia. So you can observe for some time. If it's not really going away, probably yes, you might need to intervene. So the risk factors, again, there are different scenarios here. There could be just a preoperative medial rectus limitation. There could be just, you can say, a slippage of the medial rectus. And the incident rate varies from 2 to 43% of esotropia surgery. So even in children, probably sometimes they land up in conjunctive esotropias. Of course, the workup has to be done accordingly. Do force duction test is important. Do the active force generation test to know what's happening. To so it's slippage, whether there's some kind of a contracture which has developed by the the lateral rectus. So if there is no such thing, probably then you can assume that this could be because of some kind of an over recession or a resection. So if it's within physiological limits, probably yes, you will have to intervene. But then if you're finding something abnormal on the force duction test or the force generation test, probably you'll have to tackle that first. So small overcorrections can be treated with minus lens therapy postoperatively. They stimulate accommodation. And many cases can be salvaged and reoperations avoided. You can sometimes give alternate patching for these cases and then manage them. But yes, surgical management would depend upon what you find. If it's a slipped MR, you will have to reoperate, identify the muscle. If it's a tight lateral rectus, you will have to tackle the lateral rectus. And probably yes, if you find nothing that probably and you have done you can say the maximum amount, then probably you'll have to operate the other eye for getting the sometimes probably you can for the conjunctive part you can either advance what you've done or maybe redo what is done, but in some other cases probably it's where the other eye needs to be tackled, you can do that as well. So basically again you have to talk to the patient, because this is not simple thing as an infantile exotropia. It's something which has happened after an esotropia. So you can just redo that thing of the same eye as well. So those are some of the things what I wanted to cover. Important thing is intermittent exotropia, what you should know, and how you should go and manage such conditions. Thank you.
Thank you, Dr. Jasprit, for very elaborate and nice presentation. If there are any questions, anybody would like to ask anything? They're all exhausted, I think, after two talks.
Yeah.
Anyone?
Very comprehensive, Dr. Jasprit.
Yeah.
I think what we also have a plan is that in between, whenever we get time, maybe after the neurophthal session, we might actually just discuss 5 minutes about amblyopia also.
Right.
So that's the plan.
Right.
But we'll move forward now to the next session.
Yeah.
Thank you,
Right.
my co-chairs, Professor Pandey and Professor Jasprit Sukija. Thank you so much.